Thank you. Bless you. Thank you, thank you. Okay, also, let's go over. I'm going to give you an updated schedule when you guys come back. Because this is completely confusing for you guys since you are the Monday class and you're off next week. So I tried to write over there so that you understand we will not meet in person next week, and there is nothing that you need to be doing for next Monday. We're not going to get on Zoom. We're not going to be here. You can go ahead and start reading ahead for the week that we will be here. That being said, the following week, so the week of Monday the 14th, that's your dry run for Cengage. So we will not be here in person again on the 14th. You will have things that you need to complete that week. We will not be on Zoom that week though, okay? So the 14th, you'll have things within that learning path when you sign into Cengage for you to complete. So next time we'll be in person is Monday the 21st. Okay, so those are the things that I want you to go over, chapter 43 and 46, before September 21st. And would anybody still like to have a paper copy of the skills list? Okay, majority is. Okay, so I will print out skills list for you to take home today, okay?
So will we do we have to get up like early that morning?
No, you need to complete those assignments during the week. So you don't. Once we go completely virtual, on Monday morning at 9 o'clock, we will have a Zoom meeting for about 30 minutes. Otherwise, all of the work is done on your own time during the week and has to be completed within 7 days. So by Sunday at midnight the following week, for the next Monday morning, all of those assignments have to be completed. And I am able to view on my end how many hours you've spent within the system, so we can tell that you're putting in the seat hours. And we'll go over that. I think I went over it with you guys a little bit. I showed you the learning path, right? Last week, did we look at it a little bit? Show you activities. Okay, Tuesday class, we couldn't get it to load, so I forget which one. Okay, so let's play a quick icebreaker. You have 2 sheets of index cards, pink and blue. I want you to take blue in your right hand, pink in your left hand. Also, for those of you that didn't hear, just put your name on your name tag when you get a chance, okay? So, blue in the right hand, pink in the left hand. Okay, so when I say, do you like this or that? The first one's going to be blue, second one's going to be pink, okay? So, let's start. If I'm going to say, do you like this or that? So, one thing or the other. The first thing is blue, the second thing is pink. Okay, so here's the example. Do you like coffee or tea? Coffee is blue, tea is pink. Coffee or tea? Neither? Oh, I get it. You get it. Okay, tea. All right, hot tea or sweet tea?
Sweet.
Sweet. Okay. Do you like cats or dogs? Cats are blue, dogs are pink. Dogs. Cat? None? None. Okay, cars or trucks? Cars are blue, trucks are pink. Wow, okay, all right, we're pretty divided. Okay, mountains are blue, beaches pink. Mountains? There's a couple mountains. I can't see you back there. Are you holding anything? Neither? Undecided. Okay, summer or winter? Summer is blue, winter is pink. Summer is blue, winter is pink. Not a lot of summer. Well, kind of even. Okay. Fall or spring? Fall is blue, spring is pink. I'm making you guys make a lot of decisions early in the morning. Sorry. Okay. This is an important one. Chick-fil-A is blue, McDonald's is pink. Oh, both. Neither? Neither of you like it? Oh, okay. What you said. Almost everybody says Chick-fil-A. Then we got both in the back. Okay, morning, are you an early bird, blue, or night owl, pink? Combine them both. Early bird or night owl? Kind of both. It depends. Okay, would you rather watch TV, blue, or read a book, pink? You guys are undecided over here.
Because I'm always on my phone.
There you go. Okay, so
I'm always working or with the kids. So.
neither. No time for either. Okay. Would you rather, if you were in the medical setting, would you rather work with kids blue or the elderly pink? Kids blue, elderly pink. Okay, so everybody likes kids blue. Okay, and the last one, we kind of already went over it. Blue for TV, if you'd rather watch TV. Did I tell you TV and book already? Already did it. Okay. I think I want more then. Okay, would you rather learn in person blue or virtual pink? Everybody likes in person. Understand that. Okay, one more. Are you blue, more of a hands-on person, or pink, somebody who likes to read it and understand it? Okay, all right, so hands-on. Who in here is a visual learner? Like you need to actually see it in front of you, see a picture, touch it. Okay, all right, very cool. Okay, so we'll get started. Just something silly. I'm gonna see if we can. Okay, so what we're gonna do today, first thing we're gonna do is go over chapter 36. I'm gonna talk about it, so if you have your note cards, if you need more index cards for your ring, let me know, because I've got some here. You just leave them right on your desk. The blue and the pink, leave them on your desk. Don't forget to write your name on your name tag. So, what my plan is over these next few weeks is that we're in person, just so that you guys understand. We're going over these chapters so that you can grasp the information for the skills portion of it, but you're going to see these chapters again later in the semester. So what we're going to do once you go completely virtual, we're going to start at chapter 1, we're going to go to chapter 2, we're going to go down the row. Zion, you need to get in there. Okay, hold on just a minute. You have to get the key. So we're going to start in the beginning of the book and work our way through it. Some of the chapters you will not ever even read because I think they're completely unnecessary and it's too much information. But just so that you understand, you will see all of these chapters that we're discussing. You'll see them again in your learning path. You're going to see the activities, and there will be the option to read through the chapter again. If you feel comfortable with it, if you've already read it and you're comfortable, you can click through it quickly, okay? I do want you to complete the activities because it's going to be later in the semester. The point of this is, one, we want to get your skills in early, so in case we were pushed into virtual immediately, you would have at least some of the hands-on skills. But two, we wanted you to see this information now and then read it again later. So you're it's repeating it just so that you're more comfortable. These types of skills are what you're going to be doing constantly as a medical assistant. So I want you to read it now and I want you to revisit it later. Okay? So let's talk about chapter 36, measurements and vital signs. Who does vital signs right now in their current employment? Is anybody doing vital signs on a daily basis? Checking vital signs? No? Okay. So, first thing we're going to talk about is height. When do you think it's important in an office setting to check somebody's height? Okay. So, yeah, elderly. Why the elderly? Any reason?
The reasons that I know is because they feel like they're growing shorter.
Yeah, okay, osteoporosis is the main reason. What did you say? Yeah, okay, so in the elderly, you're checking their height. Usually if they're coming for a follow-up, that may not be necessary, but at least once a year, you're checking their height because of osteoporosis. They really legitimately could be shrinking and getting shorter. So you want to check that. Infants and kids are also important because most of us know kids grow like weeds, so you're constantly checking them. So when you're doing a height, do you want their shoes on? No. Exactly. Okay, you want them, if they're willing, you want them to back up, and we've got it here on the scale. A lot of places will have it just on the wall. You want them all the way back. You want them looking like this? No. You want them looking like this?
No.
Okay, try to get them straight ahead, okay? Best thing you can do is say, look at us, but you see that spot on the wall? Give them something to distract them, especially if they're kids. Try to get them to look at it. Put it straight down on their head, measure it, document it, okay? All right, what about weight? A lot of places now have digital scales. So you're gonna have them step on the scale. Most places want them to, if they take their shoes off, they need to have socks on. Just because of things like athlete's feet, you don't want something like that spreading to patients. If you need to, they'll have like a little paper that you can put onto the scale like you would onto a baby scale for feet. But you want them on the scale. Why is it important to get an accurate weight? Any reasons you can think of?
Make sure you get the correct dosage.
Exactly. Medications. That doctor or that nurse practitioner, whoever that provider is, they're expecting that when they go into the patient's chart and look at their weight, that you've documented it correctly, because they're going to adjust that dosage of the medication based on how much they weigh. And it's completely important, absolutely crucial that with babies and little kids you get an accurate weight, because those dosages can change. It's such a minor weight change can change the dosage for them, okay? So, scales. If you don't have a digital scale, you're going to be dealing with a scale like this. Has everybody seen these before? Probably in elementary school or high school. You're welcome later when we're on a break to mess with this. Just let me know and I'll wipe it down between each of you. When you're looking at this type of scale, and look, you can see ours isn't completely accurate. It has to be calibrated because you want this arrow to be freestanding right here in the middle. Okay? You don't want to touch the top or the bottom. See right now how it's touching the bottom? I've got to figure out where it calibrates. This one's different than what I'm used to. You want it right in the middle. Okay? And when they step onto it, the first thing you're going to do, can you guys see over there? First thing you're going to do is change this lower one, okay? It's in increments of 50 pounds. So let's say you got somebody who weighs 180. Here's 150. They're stepping on it and it's still hitting the bottom. So what does that mean? You still got to keep going up, okay? So let's say if they're 180, we get to the 30 pounds up here. This is 5 pounds here. And then they're still standing on it, and now it's completely free hanging right here in the middle. That means you found their weight, okay? You want this to be sitting right in the middle like it is before they get on. Okay? Let's start with the heavier one, because it's 50 increments, 50-pound increments, and then we go to the top one, okay? That's something good to practice. If you know that you're going to have it in your office environment, just get on it. If you're on a break, you want to get there and just get on it and mess with it and toggle with it so that you feel comfortable. Because it's not something that you really want to fiddle with while you have a patient up there, especially an elderly patient who's already not very stable. You want to get comfortable with a skill like that and move it as quickly as you can. Okay? All right, the other thing with height and weight with the elderly, be cautious, okay? If you have the option to do height on the scale versus height on the wall, always choose the one where they're going to be safest, okay? So against the wall, they're going to be a lot safer on flat ground than they would on something like that. Also with that age group, you don't have to force them to turn around, okay? Because can you imagine somebody who uses a walker trying to stand this way for their weight and then turn around on a little scale to get their height checked? So just let somebody like that continue to face forward. So this here, I'm sure you guys have seen this before, but this is the way you can check height on this thing, okay? And you would actually have them stand here, pull it directly down, okay, till it's flat. Okay. All right, so let's talk about vital signs. What are vital signs? So, blood pressure, temperature, what did you say? Pulse, respirations. What's the other one that didn't used to be considered a vital sign, but now they do? No, something else. Starts with P.
Pulse.
You said pulse.
Oxygen or
No, one more. Pain. A lot of providers will consider pain as one of the vital signs now. How do you check pain? A lot of places will use a scale, so they'll have like a picture for kids, and it'll have 0. And you ask somebody to rate their pain, you say on a scale from 0 to 10. 0 being no pain. So that picture for the kids would be a big smiling face. 10 would be the worst pain of your entire life. And that would be a really sad, like disgruntled, upset, crying, tearful face, okay? So if you're asked to rate your patient's pain, all right, what would you say your pain is on a scale from 0 to 10? 0 being no pain, 10 being the worst pain you've ever experienced. Okay? Okay, temperature. Let's go for the vital signs. Let's start with temperature first. What does febrile mean? Yep, so elevated temperature. So write that down on your card. Febrile means an elevated temperature. Febrile means fever, okay? It's what normal people would say is fever. It would be documented in a patient's chart as febrile. So what do you think afebrile means? Yeah, normal, a normal temperature. A means without a fever. So temperature is often lower in the morning and it increases later in the day. Part of the reason it rises, heat production because you're moving around, and also you're metabolizing your food. So your temperature tends to start low, go a little bit higher by the end of the day. Go ahead.
Afebrile, you said is normal?
Without fever, yes.
Okay.
Yeah, normal temperature. So what's the average oral temperature?
98.
98 what? Yeah, 98.6 is considered a normal oral temperature. You want to know that, okay? 98.6 normal oral temperature. Okay, let's talk about types of thermometers. Oral. When you're using an oral thermometer, should it go just inside the patient's mouth? Right, there is a pocket. You want them to lift their tongue up and you need to push it down into one of the pockets, under the tongue, towards the back, okay? Right or left, doesn't matter, and then they need to be able to put their tongue back down, hold it down, and shut their mouth. If you have a patient that's doing this, with the thermometer in their mouth, you're not gonna get an accurate temperature. So, who should not have an oral temperature checked?
Kids.
Young kids. Who else? What about patients with dementia that can't follow directions? Those types of patients should not have an oral temperature. Most adults and most older kids are able to put it under their tongue and hold it. Most of these machines will take less than 10 seconds. Some of them are less than 5. So it's not like those old style oral thermometers where you have to wait, 30 seconds, 45 seconds, a minute. Okay? All right, what other types of thermometers? Axillary, in the armpit, okay? So that is something that you'll see on those oral thermometers in the doctor's office. They have an option where you can actually change the front screen and it can be oral or axillary. Axillary, armpit. You want to remember that. Axillary means armpit. Go ahead.
That's the least accurate, right?
Right. So what they normally say is if you get an axillary reading, it's usually about a degree higher is what their true temperature is. A lot of offices won't use axillary anymore for that reason. When you're in the setting and you're documenting their vital signs, there will be an option. If you're using an electronic record, there'll be a drop-down box and it'll say, did you use oral, did you use axillary, did you use tympanic? So the doctor will be able to see that and know which one that you have used so they can adjust that in their mind. We don't recommend that you guys add that degree on to their temperature. They just document where you took the temperature. So 98.6, axillary, if you have to write it on paper for the provider, okay? Wherever the location, make sure you document it. Okay, oral or tympanic. Anybody know what that means? Oral, A-U-R-A-L. So you want to write that one down too. A-U-R-A-L, also known as tympanic. T-Y-M-P-A-N-I-C. Yes, T-Y-M-P-A-N-I-C. In your ear, okay? This is an ear thermometer. Normally, these run about half a degree. The result will be about half a degree higher than your oral. But the important thing to know, if you're using an ear thermometer in the doctor's office, one, the ear thermometer means oral or tympanic. That's how you document it. But second thing, when you're working with, I want to make sure I tell you right. When you're working with adults, and you're putting the thermometer in their ear, grab their ear, up and back, okay? That's how you're going to get the probe into their ear. idea is that you don't want there to be any space in their ear canal. You don't want anything to be able to leak out. You want to get their true temperature from within their ear canal. So up and back for adults, down and back for kids, 5 and under. Okay, so write that down so you can remember that in the future. If you're putting your thermometer in, adults, you pull their ear up and back. Kids 5 and under, down and back. And that just has to do with how the ear canals are positioned as kids. They tend to be a little more horizontal, whereas ours go up more vertically. Okay. So next type of thermometer, the temporal artery thermometer. You can see that often as a TA thermometer. That's kind of like the one that we're using on you guys. This is like a modified temporal artery thermometer. Temporal artery is right here. Your temple, the artery that's right over your temple, okay? Going to be holding that. You have to check with your office. Some of them actually have to touch the skin. That's why we had the confusion with ours. Some actually touch the skin. So that means you need to clean it up before you have your next patient. And some of them, you just kind of point and click. Like they're using at schools right now. It looks like a gun that they're pointing at the kid's forehead or right at their temple, okay? You can also see some thermometers that will swipe along your forehead, down your temple, and like behind your ear. Those tend to not be very accurate. But that would also be a temporal artery type of thing. So they're starting here and then they're rubbing over the temporal artery and then down. Okay? All right, so that's it for thermometers. There was also something in your chapter that talked about converting Celsius to Fahrenheit. I would not worry about trying to convert that on your own. Just know that check your thermometer when you're checking the patient. Make sure it's set to Fahrenheit, okay? I've never heard of a doctor trying to use Celsius for degrees. So just make sure that you're on a correct setting when you go to take the temperature. So a lot of them won't give you, if you check somebody's temperature and you check it and it says, 13.5, you realize it's Celsius, okay? But you can't just push a button and convert it to Fahrenheit. You're gonna have to do that on your own if you need it to be documented in Fahrenheit. So just check it before you start. Make sure it's on the right setting. The other thermometer too, before I forget, if you see a case that has 2 probes, one is blue and one is red. Does anybody know what that means?
Red's the rectal.
Yep. Yep. So blue for oral, red for rectal. Oh, has anybody seen that in an office? Okay, it's a little more common like in the hospital setting because you will have patients that cannot hold it orally in their mouth. In most hospitals, if they can't hold it orally, they want it rectal. Because oral and rectal are the most accurate temperatures. Those are considered core temperatures. So oral or rectal. If you have to do a rectal thermometer, most often it would be, that patient, like a dementia, older patient that cannot hold it in their mouth. Or you have like babies, sometimes babies, even if you've had your own babies, they say until they reach a certain age, you should check their temperature rectally because it's more accurate. So one thing to remember, if you have to do a rectal temperature, obviously those probes are disposable. Please remember that. Don't ever reuse any of those probes, okay? Oral, axillary, rectal, anything. You're always throw them away and get a new one. For the rectal, you can put lubricant, just a small amount of whatever, petroleum jelly or whatever is in the office, some sort of lubricant to help access the rectum, okay? And when you're putting that into the rectum, we're talking half an inch, okay? Not, please don't try to stick the entire stick, okay? No, really. Okay? All right, so let's talk about pulse. Pulse rate, number of times the heart is beating per minute. Okay, write that down, please. Pulse rate, number of times the heart beats per minute. So what we do when checking vital signs, we're checking pulse by palpating. Palpate means touch, okay? That's one of those big fancy medical terms, it just means touch. Palpate, palpate, P-A-L-P-A-T-E. Palpate is to touch, okay? When you're checking a pulse, normally with a patient, you're going to do a radial pulse. So, radial pulse is right here at your wrist. 2 fingers. Do not use your thumb because you can sometimes feel your own pulse in your thumb. 2 fingers, like a peace sign, okay? First, 2 fingers, first, second, and third fingers, okay? to the thumb side of your wrist. Okay, push down. Go ahead and try it on yourself. 2 fingers, and you want to push down with a little bit of pressure. Put 2 fingers together, push down. Inner side, thumb side. And sometimes with older patients, it will be very hard to find. So I suggest put your thumb on the other side of the wrist so you can kind of hold a little bit more pressure. Obviously not so much pressure that you bruise them, but so that you can feel it. Okay, can everybody feel the pulse? Okay, so what I want you to do is turn around and look at the clock. Once the second hand gets to the 6, I want you to count your pulse for 30 seconds, okay? Okay, so whatever number you got, multiply it by 2 or double it, whichever way is easier for you. Okay, so what did you get? 64. What else?
76.
Okay. 76, what else? 68, okay. Anybody else? What did you guys get back there? 72. Okay. Fast. Okay. What else? 68. Bonus, what did you get?
76.
Okay. When you're going in a patient's room, you are allowed to check pulse for only 30 seconds. That's fine. And then multiply by 2 or double that number to get. When you're checking pulse rate, they want for a full minute. Okay? So you need to figure out, if it's easier for you to not try to do the math in your head in a room, just feel for a whole minute if that's what you're most comfortable with. Okay? That's completely up to you. The time that you do absolutely need to feel for an entire minute is if it's irregular. Okay? So you know how you're just going thump, thump, thump. Okay, some people who have AFib who go thump, 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 thump. Like it's completely irregular. If you ever feel that, you need to keep your fingers there for an entire minute so you get an accurate number, okay? There's no way to multiply by 2 because you don't know how many times it's going to be irregularly. Okay? Other thing with pulse, what we like to teach you guys is the best way to check respirations is while you're checking pulse, okay? Because you think about it, if you start thinking about your own breathing, you're either holding your breath or you're breathing more deeply. You're not going to breathe as regularly as you normally would if you know somebody's watching. So, what does that mean? Checking pulse on a patient to check them in at the doctor's office. So you're feeling their pulse, you're looking at your watch, you get to 30 seconds, okay? Remember that number in your head, and then start watching their breathing for the next 30 seconds. If you want to do 15 seconds, that's fine, but you got to multiply by 4. The point of respirations is a full minute too. So you want to know that, write that down. Pulse and respirations, you want to know how many respirations for a whole minute and how many beats for a whole minute, okay? So, if you want to check pulse for 30 seconds, keep your fingers on their wrists and just watch with your peripheral vision, watch their breathing, okay? Because I promise you, if you do this, they're going to say, something wrong with me, what are you doing? Why are you looking at me like this, right? And then they're going to start going, they're going to think you're getting ready to listen to their lungs or something, okay? They're not going to be breathing as regularly, okay? So try to do those two together. The other thing that I would advise you to do, even if you're in an office where you're taking either a laptop, a tablet, a Chromebook, whatever it is, into the exam room with you, have a little sticky note, have something, have a little notebook, something you can write on, because you will be shocked at how quickly you forget all those numbers when you start finishing the check-in process and asking them the questions, and they start asking you questions. You get out of the room and say, I don't remember the blood pressure, I don't remember the pulse, I don't remember the temperature. Like, right, just write it down. Take a little pen in your pocket, pull it out and just scribble it. You can throw it away, you can scratch it out, however you want to do it. But if you're somebody who thinks you might forget it quickly, just make sure you jot it down. And you don't need to put a patient's name, you don't need to put their date of birth. Just write those numbers so that you know you can document them when you leave the room, if you're not doing it as you're sitting there with them, okay? All right, so other sites for pulse. We did radial, brachial, right here in the antecubital space. So brachial is right here. If you want to put 2 fingers in the inner part, if you push down, you should be able to feel your pulse right here, where your elbow crease is, inner part. That is your brachial artery. Can everybody feel it? If you can't feel it, move it around a little bit. Push down a little harder. Sometimes it's not completely, you can't completely palpate it. Just depends. If you can feel it, this is the exact location where your stethoscope is going to go when you listen to blood pressure, okay? You're trying to hear the beats over your brachial artery. So right here, in that crease. So if you have somebody taking your blood pressure on this side, you don't want it over there, you want it right here, brachial artery, okay? This is where it's gonna stop here. All right, where else? Carotid. Does everybody know where the carotids are? Yep, either side of your neck. Don't ever push both at the same time, you might pass out, okay? You're not gonna have enough blood supply to your brain. 2 fingers, same thing. You can feel your trachea going right midline. If you're a man, you can feel your Adam's apple there. Right to the left or right to the right. 2 fingers, same thing. Does everybody feel that? Okay, femoral. F-E-M-O-R-A-L. Means groin. Yeah, in your groin. So, 2 fingers, same way. You can feel it. You don't have to do it right now, but you can actually feel it if you push down hard enough. This is where they do cardiac catheterizations. If you've ever heard of a cath lab, a heart lab, where they're going in to check somebody's heart, check their arteries, they actually start the IV tubing here in their groin. They have to thread it all the way up their abdominal aorta into their heart. Start in their groin though. All right, dorsalis pedis. That's one that you don't ever really need to document, but it's good to know. If you have kids, when you've gone to a doctor's office and they're giving your kids their annual physical, even if you don't notice it while they're talking to their kid, they're going to push on the top of their foot, okay? They're feeling for their pulse on their foot. If you check, and if you have socks on, don't worry about it now, but right in the middle, top of your foot, okay? You will feel your pulse, 2 fingers, top of your foot. And that's one that you can feel really well in kids. It's a strong pulse. If there isn't a strong pulse there, they're worried about their circulation, okay? All right, and then popliteal is the last place for a pulse. Popliteal is back of the knee, okay? 2 fingers again, right in the back of the knee. These are all locations of arteries. So the arteries are the ones that are pumping hard, you're gonna be able to feel well. You check them on top of a bony area, because it's easier to push down and feel it, okay? Just like right here, radial pulse. You're pushing down onto your radial bone, okay? Your radius. All right, does anybody need a break? Do you need a mask break, Zion? I saw you pulling down your mask. You guys want a break for a second? Get outside and get your masks off? Anybody? It's okay. Everybody okay? Okay. Okay, so let's talk about what's a normal pulse rate. For an average adult, 60 to 100. You want to write that down. Average pulse for an adult, 60 to 100 beats per minute. BPM is the way you're going to see that. BPM means beats per minute. So average adult, 60 to 100 beats per minute. Okay, younger kids are going to have a much faster heart rate. Older people, their heart rate is going to continue to slow because their heart doesn't function as well as a younger adult. Okay. Okay, what happens to your heart rate when you're exercising?
It speeds up.
Right. Okay. It's normal for it to go at least 30 beats higher than it usually is at a resting heart rate. But often if you're doing some sort of cardio, it'll go even above that. Okay. So, athletes, they're the ones you'll see who have extremely slow pulses because their circulatory system, their heart, is able to handle the amount of exercise that it's doing all the they have very slow pulses. Okay, so 2 things to write down. Tachycardia, Tachy, tachycardia, Cardia. Does anybody need me to write this down? You guys get it? Okay, so tachycardia, an elevated heart rate. That means above that 100 beats per minute would be considered tachycardia. Tachy means fast. Cardia, heart rate, heart, okay? The next one is bradycardia. B-R-A-D-Y. Brady, same as the other one, cardia. C-A-R-D-I-A. Brady means slow. So this is somebody who's going to have a heart rate below 60 beats per minute. So I always remembered it tachy. So think about it. If you're doing a project the night before the assignment's due, and you're going really, really fast, maybe it's going to look tacky because you're going too fast, okay? You have to find some way to remember the opposites. But tachy, too fast, bradycardia, too slow. These are things, you'll see these diagnoses in a patient's chart and you'll say, oh, I know what that means now. Just a fancy word for heart rate, okay? All right, the other place to take a pulse is one that you won't do commonly in an office setting, but it's an apical pulse, okay? So that is actually taking your stethoscope or your hand and touching at the apex or at the bottom of the heart. So 5th intercostal is what we say. Intercostal means in between your ribs. So if you start right here under, you're going to actually be able to feel the space in between your ribs, and you go down 5, 1, 2, 3, 4, 5. You're going to end up right about here. And you can actually put your stethoscope and hear the heart really well. Okay, apical, the apex of your heart. And that's when infants especially, you'll see providers listening to their heart because you can't get a very accurate reading on their wrist, okay? And infants' heart rates, I mean, like 120 to 180 is considered normal for an infant. So it's really fast. Those are the patients I highly recommend you listen for an entire minute. Do not try to multiply a number because it is beating so incredibly fast that you need to just count for a whole minute. Same thing with the respirations. You'll find they're breathing very quickly. Take your time in this really young patient, okay? You want to make sure it's accurate. Okay, pulse oximetry. Has anybody seen that? The little thing they stick on your finger. These things are awesome. You know why? It's checking the pulse for you. So if you're in an office that uses a pulse ox, you may not even have to check the patient's radial pulse. It would show you the pulse and their oxygen level. So if you're not an office that uses these regularly, this is the type of thing that you pull out and check if the patient's having respiratory symptoms. If you're in a pediatric office and you're having constant coughing, if they're short of breath, if they have pneumonia type of symptoms, and the doctor's concerned, they're going to say, go get the pulse ox, okay? In adults, you're going to stick it on their index finger. It's an infrared sensor, so if they have on nail polish, that's a problem. Especially if it's a dark nail polish or if it's artificial nails, you're not going to get an accurate reading. They may say, check a toe, check a finger that doesn't have nail polish on it, okay? On the finger, oxygen level and pulse, it'll show you. In kids, they'll often tape it like around their big toe and check it the same way. With those patients, if you see oxygen rate, what we want the oxygen rate to be is 95 to 100. So you can write that down. Write down pulse ox, pulse, and then ox, O-X. So it means oximetry, but pulse ox is how we refer to it. So you want to see a reading where it's going to show a percentage. You want it to be 95 or higher. If you see it going below that 95, especially if you see it going below 90, you do not wait. You go and find the provider. I don't care if you're knocking on their door and they're with another patient. You need to say, I need you to know that this is the patient's oxygen level. If they get below 90 and they're in the 80s, or they're in the 70s, or they're in the 60s, it's a pretty urgent situation, okay? They're not getting enough oxygen. They are very sick, and they need to seek more medical care than where they're at right now, okay? So If it's below 95, what you can do is tell them, especially if they're older, say, take some nice big deep breaths. Sometimes that'll bring it up. With a lot of those patients, whether they're older and they don't take the deep breaths, or if you have people that are like morbidly obese, they don't tend to take those large deep breaths. Okay? So first, have them take some deep breaths. If you don't see it going up at all, please go find a provider, go find your clinical supervisor, whoever it is that you're comfortable going to, let somebody know, okay? And that's the same way with any vital signs. If you go in, somebody has a really high fever, somebody needs to know about right now, okay? If they have an unbelievably slow pulse rate and they're not an athlete, that's what they start. If they have an incredibly high heart rate, they're probably fighting off an infection, okay? Heart rate's not as major as oxygen. Pulse and heart rate, yeah, I wouldn't be as concerned about that. But blood pressure, if their blood pressure is extremely high, same thing as with the pulse ox. If the oxygen level or blood pressure are high, somebody needs to know right now. ASAP, that does not wait until you check in 2 or 3 more patients. You gotta tell them right now, okay? I had a patient one time that came into the doctor's office and he was on blood pressure medication. He was a cross-country truck driver, and he would not take his medication for weeks at a time. Either he'd forget it at home, or he was so tired from driving on the road, he just didn't feel like taking his meds. And he was probably just shy of 500 pounds. He was a very big guy. He could not get his blood pressure on his arm, and we'd have to do it on his thigh. And every time he would come, it was nothing for it to be 220 over 110. 240 over 150. I mean, I'm talking really high numbers. That is not normal. Somebody needs to know, okay? That's like stroke level.
That's what they say about it.
It's amazing. It was a miracle he had. But those kinds of high readings, you need to notify, okay? Okay. The other thing with the pulse ox too, if you see on that little finger pulse ox that the pulse is reading something really, really high or really, really low, you need to check it manually too, okay? Don't just assume that this is the only reading. Check it manually if you're concerned that it might not be accurate, okay? Especially if you see something that's extremely high. You want to recheck it on your own. Okay, respirations. Respiration is the combination of a total inhalation, which means breathing in, and an exhalation, breathing out. Okay, so this is not a respiration. This is. So you want to see the chest rise and fall. That equals 1, okay? So, it's 1. It's 2, okay? When you're dealing with really little kids, you're gonna see this. They're gonna breathe really quickly. In and out is 1. In and out 2. In and out 3. You don't count in 1, out 2. In 3, out 4. Okay. Total inhalation, total exhalation. Breathing in, breathing out. Okay. Hyperventilation. Does everybody know what that means? Okay. What does it mean? Yeah, breathing too fast and too deep. Hyperventilation is one of those words that you'll see often. Excessively fast and deep breathing. Okay, here's another term I want you to know. Dyspnea. D-Y-S-P-N-E-A. Dyspnea. This will most often mean shortness of breath, okay? And you may see it documented S-O-B, all caps. Like you see one of those, that bad word that people used to say all the time. You say, what is S-O-B? Okay. So dyspnea, S-O-B, shortness of breath. Okay. Difficult labored breathing. Struggling to breathe, struggling to catch the breath. These are the patients who will be using those accessory muscles when they're trying to breathe. So you see little kids, if you've got a kid who's really sick at home with respiratory issues, you will see them here. Or you see retractions here. You can pull their shirt up and see along their ribs. You can see it almost tugging, like the skin is tugging. They're not just breathing heavily here, they're using extra muscles to try to get those deep breaths in, okay? Shortness of breath, dyspnea, using those extra muscles. All right, rails, R-A-L-E-S. This is noisy breathing. Something is constricting their airway, okay? This is your bronchitis, your bronchitis, your pneumonia.
But there's some people just really,
Yeah,
noisy because they breathe.
it can be, it can.
That's
But pneumonia, bronchitis, and asthma, those are the common ones where you don't even have to put a stethoscope on them, you can hear it. Usually the rails, it's more like mucus. There's some sort of mucus in the airway. You don't ever have to check it, you can hear it, okay, rails. Next one is apnea. Has anybody heard of sleep apnea? Okay, that's something common at night. Apnea means absence of breathing. A means without, okay? Apnea, without breathing, or an absence of breathing. So those are those patients I was telling you about. If you're checking their pulse, and you're trying to check their respirations, they might, without even realizing it, have apnea because they're thinking about the breathing. So rather than taking their normal breaths, they're holding their breath. And they breathe in. Or you've got those patients who have sleep apnea, where at night they're breathing consistently, and all of a sudden they're holding their breath, they're not taking a breath. And then you feel like, and then they'll breathe normally again. And go through that same cycle. Those are the people who wear those 5-hat, CPAP type of things. Okay? All right, everybody stand up. Up, arms up to the sky, stretch. I know this is boring, I'm sorry, it's a lot of dry information. All right, reach to the right. Reach to the left. All right, touch toes. Touch toes. All right, stand up. High knees, left knee, right knee, left knee, right knee. Okay, go take a break. Come back at 10, and we'll finish here.
You know you got more than one here. Yeah, because I wrote Kayla. I'm at school book. Where's Ronnie? My son said he wants to see my teacher. Hi, how are you? Good, hi. Oh, I like your hair bows. Those hair bows are the bees. Hair bows. Yes, yeah, it's great. I'm going to continue recording. I was just going to send her a message to tell her we're on break. But yes, it's great.
Good, okay. Do you happen to know what happened to the mannequin with the detached lower leg?
I think, let me come check. I think Robbie took it to the high school.
Okay, well, I'll email her because I got the parts of it.
Yeah,
My teacher walked out. You see the hi, mommy's man. Dude, hi, Steve. Is Kayla here? She went outside. I'll be there by 1 o'clock. Right. No, I'll be there today. All right, love you. Bye. Check to make sure she didn't have nothing to do this morning. Check to make sure she didn't have nothing to do this morning. What your party is after this? Okay. I just want Harmony, it was on this Harmony get on live for reading and stuff. The time she get on live for reading and stuff. Harmony. Cause that's someone I'm not sure about that, cause Harmony is not, it's reading. But she's struggling. Bad. Well, she don't have access anymore. Yeah, but then I won't be able to, but that's what she's trying. I was struggling with math, Harmony's struggling with reading and it's by the couch. It's by the couch. Hold on, let me go look. This kid's supposed to be out. Yeah. Ew. They do. If I was going all the way off the you didn't hire anyone. That's a straight needle for when you draw blood. You connect the hubs with it. So we see her gag and alright, well, guys, about to start doing. I said, you know, you sit back and think about what you did. Yeah.
Okay, is everybody back? Alright, so what we're gonna do, we're gonna talk about the last thing in chapter 36, which is blood pressure. And then I'm gonna pass out blood pressure cuffs and stethoscopes. I'm gonna let you guys practice a little bit at your desk, and then I'm gonna take you in one by one to the lab. And I just want you to practice the process. We have a mannequin in there. Use name or whatever you want. For him, didn't check. And I want you to practice the process of doing all these vital signs on the mannequin. It's gonna take a little while because what I have to do after one of you goes in, I need to wipe down the mannequin, let it dry for a minute, and then we'll get the second person in, okay? So just to go over the skill with you one-on-one, you can ask any questions. Unfortunately, I can't let you practice on each other, and they won't let me have you practice on me, which is what I wanted to do, so that you could hear the stethoscope we have. It's a double stethoscope, so I would be able to hear what you're hearing too. I'm gonna look for some videos for you guys to watch while I'm in there one-on-one, okay, with each of you. After that, if we still have time, we're only an hour in, I'm gonna go ahead and start talking about chapter 43. I'm going to show you some of this stuff. And so then the next 2 weeks, you can read that chapter on your own, which you will have already seen this stuff, heard about this stuff, okay? So we'll just see how far we get today. Okay, so blood pressure. Fluctuating pressure within the heart. When you're checking the blood pressure, you're listening for 2 sounds, the contraction and the relaxation. So systolic, S-Y-S-T-O-L-I-C, systolic over diastolic, D-I-A-S-T-O-L-I-C, systolic over diastolic. So that's where you get your 120 over 80. 120 over 80 is considered a normal blood pressure, okay? The idea here is you've got pressure in the artery walls. When your heart is contracting, you're getting that top number, the systolic. When your heart is relaxed, you're getting that bottom number, the diastolic, okay? So you're listening for 2 separate beats. When you have the blood pressure cuff on, we're going to talk about this too. When you're putting it on a patient's arm, you want them to be sitting in a normal position, legs flat down on the floor, arm out. If you can, you want the arm to be at a similar height to the heart. If not, down a little bit is okay. Left arm, right arm, doesn't matter, except, anybody think of the one exception? When the arm side matters?
If you had like infection or
Yeah.
or maybe something, so that can be medical, like.
Yeah, so like a mastectomy, if you have somebody who's had breast cancer, who's had a breast removed, if they've had any connection in that cancer and that mastectomy to any of the lymph nodes, you always want to ask them. They'll tell you, I mean, don't worry, most of these patients will tell you, I've had a mastectomy, you can't use that side. The reasoning is squeezing on that arm can affect those lymph nodes, which can then get infected. It can cause the pain, it can cause swelling, it can cause infection, and that infection can go throughout their body, okay? So if they have a mastectomy, only on one side, always opt for the opposite side. If they've had it on both sides, ask them. The patient is the best, they will tell you. They'll tell you which one they prefer, which one doesn't cause them pain or discomfort, or less swelling. So they'll tell you. But always be cautious of that. Okay, so putting the cuff on, you're going to want to put it on their arm. You want to be able to slide 2 fingers under the cuff, okay? You don't want it to be so tight that there's no space under it. You want it to be at least 2 inches up from where your arm bends, okay? So here's your elbow. The AM to cubital space is what they call this. You want that cuff up a couple inches, okay? When you look at the cuff, you'll see it'll say right arm or left arm, and there'll be an arrow. The idea there is that you want to try to match it up. They don't always manufacture them perfectly, but try to match it up because you're going to put it, remember where you felt your pulse, if you found it earlier, along that brachial artery? You want that arrow to be close. Because that's giving you your sign. Okay, I'm going to put my stethoscope right there. Okay? So, right where you felt your pulse is where you want your stethoscope when you start to pump it up. Okay? So, we're going to practice twisting. We're going to practice pumping. That's something that is really important when you take this home with the rest of your kit. Just practice it. Practice it on family members. Practice it. You can put it on your ankle. You can put it on your forearm. Practice it yourself. Okay? Practice just the pumping and releasing. You want to be able to hold your stethoscope with one hand and be able to pump and release. So the concept of releasing, you're twisting that little knob, but you want to be able to do it one-handed. Just keep practicing, okay? It doesn't come naturally. You just have to keep trying again and again, okay? So you're putting it right onto right here, the brachial artery, and you're going to pump up the cuff until you get at least 30 points higher than what's anticipated. So let's say 120 over 80 is what you're anticipating. So if it's 120, that means 30 points higher than that would be 150. I would say safe space is between 160 and 180. Pump up to between 160 and 180. Then start releasing. And when you release, you don't go full blast and undo it. You go very slowly. You want it to tick like 2 at a time. Okay? You want it very slow. Obviously, you don't want to go so slow that the patient is in major pain and it's taking you minutes to complete it, but you need to go slow enough that you can hear it, okay? First beat you hear. First thump. or systolic, okay? First thumb you hear, whether it's 120, if they have high blood pressure, it might be 140, okay? First thumb, write down that number or remember that number, okay? And you're gonna keep hearing thump, 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 thump. Last thump you hear is your bottom number, okay? Your diastolic. First you hear systolic, last you hear diastolic, okay? So remember the first beat and the last beat you hear. Now, you can still see it jumping on the dial if you want to go based off of what you hear, okay? And the book was suggesting that some places feel that you should go with the quieter sound versus the last sound. We were always taught last sound you hear is the diastolic, okay? Okay, so what is hypertension? High blood pressure. Hyper means high. High blood pressure, okay? Hypertension. That's something you're going to see a lot of in any sort of medical setting. So, stage 1 is considered, and you don't need to know this, but stage 1 is considered 140 to 159. That top number is considered stage 1. There's multiple stages of high blood pressure. Does anybody know what high blood pressure is often related to? It's connected to your kidneys often. It's often connected to kidney disease. It can be genetic. It can be from salt intake or too much high fat intake. There's a lot of reasons, but your blood pressure is directly connected to your kidney function too, which is interesting. It seems like it wouldn't be. Okay, so salt, stress, obesity, sedentary lifestyle, aging, older population tend to have higher blood pressure, okay? It's harder for their heart to pump, to continue to pump. Genetics. Sometimes you'll have a person that looks completely physically fit, active, eats well, and they'll still have high blood pressure because sometimes it's just genetics, okay?
It's important to know the primary secondary.
No, I would not worry about that. Do not worry about primary hypertension, secondary hypertension. I would not worry about memorizing those numbers. Just knowing that the average is 120 over 80, and if you're getting above that, you're heading towards hypertension, okay? So what is the opposite of hypertension? Hyper is high. Hypotension is low blood pressure, okay? Hypo, H-Y-P-O. Hypotension is low blood pressure. If it's below 90 over 60, they're considering that hypotension. So some causes of that. Dehydration, if you have a burn victim, somebody who's in shock or they're hemorrhaging, they have severe bleeding, those are the type of people whose blood pressures are going to be extremely low. You also have some patients who below 90 over 60 is their norm, okay? And that's something you can always check in their chart. If you get a really low reading, go back in their chart and check it and look at what their previous readings were, and it'll give you an idea if that's something that's normal for them or if that's something that's abnormal and should be brought up to the doctor. Same thing with high blood pressure. Like I said before, if it's extremely high, somebody needs to know right away. If it's teetering on that elevated blood pressure, look at their previous ones. See if that's pretty characteristic for them, okay? All right, the other thing, excuse me, the other thing that you guys will do a lot of in an office environment, is they tell you to check their orthostatic pressures, so the orthostatic blood pressure. So orthostatic, O-R-T-H-O-S-T-A-T-I-C. There's something called orthostatic hypotension. So what this means is you've got a patient who's getting, often they'll come in because they're complaining of dizziness, okay? So the provider's gonna have them sit, check their blood pressure, and then you're gonna have them stand, check their blood pressure, same arm, check their blood pressure again. But if they have orthostatic, which means walking, moving, hypotension, that means when they go from this to this, their blood pressure is going to drop, okay? You want to see this a lot with patients who are older, people who are anemic. You see it a lot with patients after surgeries. They've had a lot of medications, they're on a lot of pain medications, they've had a lot of anesthetic. This process right here causes people to drop because the blood pressure gets too low and they pass out. Okay, so if you have a provider say, I need you to check their orthostatic blood pressure, that's what that means. Sitting, check it. Standing, check it again. You'll have to document both of those. Okay. All right, so you get bonus points if you can figure out how to say this. Sigma-monomer.
Where's it at?
Right here. Sigma-monomer. All right, blood pressure cuff. Okay. Sigma-monitor. Okay, sigma-monitor. Sigma-monitor. Yeah. Okay, blood pressure cuff. All right, you're gonna have all different sizes. Comes a little wrench. I don't know why. Pretty cool. Oh, and a rotate. Okay, so you're gonna have all different sizes. Typically, you're gonna be using the medium size. You will see ones that are significantly larger. You want those for your larger patients, maybe for a forearm, maybe for a thigh. Just ask, okay? The best thing you can do when you get into these environments is ask. Ask your clinical supervisor, ask your fellow employees. People are there to help you, okay? Did you have a question? Oh, no. Oh, I thought somebody raised their hand. Okay. If you see this, once you guys get your kits, you're going to just attach this here, okay? So, like I was telling you before, if you look here, it'll say where the artery is. So you want to try to line this up as best as possible just to help you out, okay? So, on the arm, it's tricky to do on yourself, but once you put it on, this is a little bit loose, but you want to get 2 fingers underneath, okay? 2 fingers under, make sure it's not too tight. If you start to pump it up and you can hear the Velcro popping as you're pumping it up, that means you probably need to get a larger size cuff, okay? It's already too tight as the air is going into it. Now, this is what I want you guys to practice on your kit. If you've ever heard righty tighty, lefty loosey, this is a good time to learn that, okay? So, right and tight. You're going to pump it. You're going to pump until you see it get up, and you'll be able to see it like between 160 and 180. Once it gets up to there, I'm at 240, you're going to barely release it. Okay, you want to release it slowly. So it's just barely jumping. And then you'll start hearing it. The cool thing too that helps you is you'll actually see it jumping too on this little thing. But always go off of what you hear. Okay? And then once you hear the last beat, totally release it so the patient isn't still feeling pressure. Okay? So hear your first beat, hear your last beat, totally release it, let the air out. Good thing to know with the cuff, never, ever pump a cuff up if it still has air in it. Okay? Don't put it on a patient with air in it and then start pumping from there. Make sure it's completely flat, completely released, left, loose, so get all the air out. Okay? And always practice this before you go in, because what will happen too is you'll start pumping and watch this. Can you guys hear that? Yeah. Can you guys hear that? Okay, it means it's not tight. Okay? Don't want to hear air coming out of it. You want it to continue to get tighter, you want to see that number down. If it's not, if it's staying really low, and you stay in the same spot, it means it's too loose. Okay? But also, don't pull it so tight that then you're like, oh shoot, I can't undo it. You're fiddling and trying to release it while you put aside that step scoop. Okay? Other things to know. It is normal for your blood pressure reading to be different from arm to arm. Okay? 10 to 20 points or so is considered normal. Sometimes providers will have you check both sides. Left side tends to be more accurate because it's closest to the heart. But providers sometimes will say, check both sides for me. Another thing to know too is the skills list. I don't completely agree with the process of what they're having you do. I don't think you need to pump it up and feel for an artery first, like the skills list suggested. I just want you to practice the concept of putting this on, placing the stethoscope in the correct spot, pumping it up, and hearing the noises. Okay. Okay, so only other thing, like I suggested before, right size cuff. If the cuff is too small, it's gonna be the opposite. So cuff is too small, your reading is gonna be falsely high. Cuff is too large, your reading is gonna be falsely low. So try to always make sure you have a correct size cuff before you ever put it on the patient, okay? All right, so go ahead and undo these boxes. And we'll start practicing this. And I'm gonna pull up a video for you guys. And if you would like to, it's fine with me if you wanna go ahead and take the blood pressure cuff and the stethoscope home today. So that you can start practicing at home today. But just make sure that all of these things are returned at the end of the semester, okay? Everybody has one? Yes, everything comes back at the end of the semester. Another thing too that Robin and I were talking about just recently is that the new norm is not to put your stethoscope around your neck. Okay, that's something that we always did in the hospital because it's easy to get out of the way quickly, especially because of COVID, but also just in general, it's a new mandate that you don't keep it around your neck. Okay, so that's why it's good to have spread tops, large pockets to be able to put it down in. Best practice too is to always take an alcohol swab and wipe the tip of that stethoscope after you have checked the patient's blood pressure. Okay. So go ahead and once you get your blood pressure cuff out, go ahead and put the little meter, attach it there. Okay, so after your meter's attached,
How short is it?
just enough so that it's on, yeah, as high as you can. So depending on if you're right-handed or left-handed, what I always found was easiest was to hold the stethoscope, the tip of the stethoscope with my dominant hand. So my right hand is where I would be holding to listen to the blood pressure, using my left hand to twist the knob, okay, to control the pump. So what I want you to do is just practice squeezing it, whichever hand you think you'll be using to check blood pressure. Use that hand to squeeze it with, and I want you to tighten it and loosen it, let the air out. And Robin suggests you find your ankle, so if you want to attach it up to your ankle, to your shin, above your ankle, to get the feeling of tightening it, squeezing it, releasing it.
Is that what you do?
Yes, undo it all the way there. And you'll be able to tell too when it has air left in it. If it has a lot and it's not releasing, grab the little balloon and undo it all the way. Okay, so once you practice squeezing it and releasing it, go ahead and grab out your stethoscope.
So how far did you say you broke it up to? Last round I knew that.
Tighten it the other way. So you're loosening it.
Yeah, that's probably exciting.
Let all the air out. Do it all. Let all the air out and then tighten it all the way. So twist it the opposite way. keep going. Okay, for the stethoscope. I'll wait till I have down. The other thing to remember too when you're checking a blood pressure, if you check it on one arm and you're concerned that it might not be accurate, don't immediately release it and pump it right back up. The book suggests you wait at least 30 seconds. I say wait a minute or two. It's not going to be as accurate if you just constricted the artery. Okay, when you have your stethoscope out, look at it. You see how the earpieces are pointing forward. I want you to put it in front of you so that they're pointing towards the front of the room. Yep. Okay. This is how you need to put them on every time, okay? Because your ear canals go in. You want this to go in. If you turn them backwards, you're not going to hear anything at all. Okay? So I want you to put them in your ears. Go ahead, put them in your ears. Yep. Okay. So best way to check if you have them on right, grab this. Go ahead and grab the base of it. Tap it. If you hear that tap, you got it right away, okay? If that tap is uncomfortably loud. Other thing you can do, put it right to your heart and listen. Take a deep breath. Can you hear it? Can anybody not hear it? You might have too many layers on your left. Can you hear it? Hold it a little lower to try to listen to your heart. Kind of lower. So that's always good practice to check before you do somebody's blood pressure. Make sure these are on correctly. Tap it if you're not completely sure that you have it the right way. The other thing to know about these Littman stethoscopes is that it does twist. Because sometimes providers will use a smaller side to listen to like babies. For our purposes, you just need to use the large side. But if you put it in, it takes you forward and you can't hear, just know that it's maybe twisted fun. Okay? So try it. Put it back on, twist the tip, tap it. Do not touch it. Do not touch your tip. Feel that? So, oh, yeah. So just know that if you can't hear it and know it in the right way, you might have this stiff twist. Okay. Tap it, double check it. Okay, so what I'm going to have you guys do is just play around with these. If you want to put it on your forearm, if you want to put it on your leg. Forearm I'd recommend only because you can actually put it on your forearm and place this here. Place it right on the radial and you'll be able to hear it. So let me show you. Also good to know is the same thing applies even if you're using an automatic blood pressure machine. Same thing applies. You don't want it to be too tight. You want it to be the right cup. Okay. Those cords do detach so you can replace the cup with a different size cup if need be. And always know that even if your office is using an automatic blood pressure machine, they always have manual cups. So if you question the results of that machine, go grab a cup and check it yourself. Okay. All right, so you put it on your forearm. The other nice thing about this is it's good if you're checking a family member or checking the patient. This has a clip on the back that will actually attach right here. Okay, so you don't have to worry about pulling it. For our purposes, if you're trying to check yourself, it's a little tricky to have it turned upside down. But what I want you to do is get comfortable deciding which hand you're going to hold the stethoscope in and which hand you would hold the balloon. Okay. So you may not get it completely accurately because it's hard to do it on yourself, but you'll get the idea, okay? So, the first thing you want to do, tap it, make Next thing you want to do after the top is on, check it sure that you get 2 fingers under. Here it is.
If we pull our jackets up, we don't have to.
What do you say?
If I pull my jacket up, I'll do that.
That I would suggest to take it off. I mean, we're just practicing, but I just really want you to go through the motion. It's likely not to get accurate anyways, because we don't have that on your arm. You don't have what? You don't have what? I know, we got more, we ordered more, they're coming. We don't need them yet, we'll need them in a couple weeks. Okay, so once you get it attached, blood pressure cuff on your arm, tap this, stethoscope on pressure here. If you're right-handed, I recommend you put the stethoscope in your right hand. This is really cool too. You can slide 2 fingers on either side so that you're holding it without having to do it. So this is good to know too. If you're rubbing your fingers all over this, you're going to hear that noise. Rub your finger all over the stethoscope, see if you hear it. Wiggle it around. You want to keep it as still as possible. I recommend a finger on each side to hold it. That way, if you need to put pressure, you can use your thumb to hold the arm, the wrist, or whatever down. Okay? You're going to hold it right over the artery. Sorry, I can't hear you guys very well. I'm underwater. Okay. Make sure your balloon is completely tight, all the way twisted to the right. Okay, right over the artery, and then go ahead and start squeezing. You want to be able to see that. If you can see it, that's fine. If you can't, detach it. Hold a little. Yep. You want to squeeze. Make sure it's tight enough that you can see that number going up. Okay, and then slowly release. Try to slowly release.
I'm not good at mouth, I'm not good at juggling this.
What you say?
I'm not good at juggling this.
This is not a normal situation. Normally we practice on each other.
Okay.
But I want you to really get comfortable with those practices. We'll do this, so you're gonna have to use those. If you want to try your leg instead of your arm, that's fine. Mine gave a really high rating on my arm, so you're not gonna be completely accurate when you're checking yourself. Going up, there you go. Anybody have questions? Okay, so if you give me a minute, I'm gonna pull up the video for you. Actually, just go ahead now and practice. Keep practicing with your cup. We'll do video later. And I'm gonna take one at a time just to practice putting it on me. Okay? Go ahead. Practice your cup. And you need 2 things ready.